My name is Nathan Quig. I'm currently a fourth-year neurosurgery resident at UNC. My talk is an introduction to the Sellar Region anatomy from an endoscopic approach. We'll mainly focus on approaches and anatomy relevant to pituitary adenoma surgery. It's important to start conceptualizing this anatomy in a 360-degree view. What does the anatomy look like from above, from below, and laterally? I really enjoyed these surgeries, and the skull-based team at UNC is a major strength of our program. Most of the photos in this talk have been collected over time from Dr. Al Roten. I've also used the Neurosurgical Atlas. I was fortunate enough to go to the UPMC skull-based course, and then also JNS has a focus collection of videos on endoscopic skull-based surgery, which is a really good resource. The endonasal approach is not limited to the Sellar region. You can address pathology from the frontal sinus all the way down to C2. The pathology location determines your approach and your opening. The approach and opening for the three tumors here would be widely different, going through the clivus, the tuberculum, and then the planum here. There's a huge range of pathology that can be addressed through an endonasal approach, like vascular lesions such as a dural AV fistula, calf mals, aneurysms, tumors, CSF leaks, encephaloceles, C1-2 pathology like basilar invagination. But in this talk, we'll mostly focus on the sellar and planar regions. And it's also important to think about what are your limitations to an endonasal approach. Would certain tumors or pathologies be better approached by an open approach? Limitations are the carotid arteries laterally, displacement of the optic nerves and other cranial nerves in the cavernous sinus, the ACAs, and extent of third ventricular involvement. The nose for the neurosurgeon. It's not an anatomy that we think about a lot, but at a minimum, you should be able to safely identify the landmarks to the sphenoid sinus and know the basic steps of harvesting a nasal septal flap. The sagittal view here gives you a good image of the distance between the frontal sinus and the sphenoid sinus. Also highlights the inferior turbinate, middle turbinate, and superior turbinate. Just a basic understanding of what the nasal septal flap is. It's a pedicularized flap that harvests mucosa off of the nasal septum. It's largely used to repair skull-based defects and create a watertight closure. The sphenoid sinus is a very orienting location to most neurosurgeons. The sphenoid sinus is located in the center of the sphenoid bone and anterior and inferior to the sella. Access to the sphenoid sinus is gained through the natural ostium, which is located just posterior and medial to the superior turbinate. Once inside the sinus, the inner sinus septum is further removed to gain full exposure. The septum is not a midline structure. In fact, the septum 80% of the time leads towards a carotid artery. Now, once we're in the sphenoid sinus and the exposure is complete, we can start identifying important landmarks. I like to start from the most inferior portion of the clival recess. The clival recess is approximately the upper 1/3 of the clivus. The lateral borders of the clival recess are the paraclival carotid. Then working up is the sella. Next, moving up is the tuberculum sella, and then you have the sphenoid limbus. Sphenoid limbus is usually a ridge of bone that demarcates where the optic nerves are, with below being the chiasmatic groove. Next, moving forward anteriorly towards the anterior skull base is the planum sphenale. Once we've had the midline structures identified, you can see things like the optic nerve, the paraclinoidal or cavernous carotid, and then the opticocarotid recesses, which we'll call the OCRs. From above, you can see these relationships here. The dorsum sellae is essentially a continuation. It's the terminal end of the clival recess. Then you have the sella. The tuberculum sella is this ridge of bone, and then you have the chiasmatic groove, which generally right here is the sphenoid limbus, which is an important landmark to avoid injury to the optic nerves. We'll just further reveal a little bit more about the differences between the sella the tuberculum and the planum. The dotted line here from the above picture and from the below picture is the sphenoid limbus. From below it's a ridge of bone, and from above it's a fold of dura that demarcates where the optic nerves are. And inferiorly to the limbus is the chiasmatic recess or chiasmatic groove, where the optic nerves come together to form the optic chiasm. Just below that is the tuberculum sella, and then the sella proper. You'll hear a lot of people call it just the sellar face, referring to kind of this region right here. You can further identify the carotid arteries, your OCRs, and your clival recess. These pictures show what the next view is with the bone removed and the dura exposed. The landmarks remain the same for the most part, and these landmarks guide your dural opening. The picture on the left is a cadaveric dissection. The picture on the right is an intraoperative view. In these pictures, you can see the clival recess, the sellar dura, the dura where underneath where the tuberculum bone has been removed, the chiasmatic sulcus and groove, the sphenoid limbus, and the transition to the planum where the bone's been left on. Laterally, you can see the carotid arteries and the optic nerves. This will conclude the basic anatomy of the sellar approaches. The intradural anatomy is a bit more complex and will be saved for another lecture. I hope this has been a useful talk for understanding the basic anatomy of the sellar region and the anterior skull base. The anatomy can get a lot more complicated as you go further inferiorly, and certainly a lot more complicated as you go laterally. This picture here is at the conclusion of a planum meningioma resection. Can you walk yourself through the approach, the landmarks that you would need to identify, and the bony exposure required to achieve this view? And then also what intracranial structures can you identify? Also, please follow us on Twitter at UNC Neurosurgery for information on future educational content.